you have given us insight into the pandemic that we have experienced around us. You have shared some of your personal interaction or your personal journey with COVID, and some of your family life also. And it was a very interesting contribution that you made towards the magazine that we have put out, issue 3. But let me ask you, what exactly do you mean with COVID light? And I asked that on the back of something that I've heard this morning only. What struck me about just one sentence, it's the second consecutive day that we had more than 2,000 infections in our country. And I know that we've been coming from 10,000 initially when we have in the perceived, or in what was called the first wave, and a year now, the second wave. But you mentioned something of COVID light. So would you be able to tell me exactly what do you mean with COVID light?
Okay, thank you very much, Raven, for the opportunity. Let's just, by way of example, look at some statistics. The Worldometer, that some of you may know of, is a statistical meter of just about everything and anything that's happening in the world today. Now, and they update it on a daily basis. Now, I checked this Worldometer last Monday, the 19th of October. And on that day in South Africa, there were almost 704 recorded infections to date since the start of the infection. But of which 634,500 had already recovered. And unfortunately, just over 18,000 people had passed away. So at that time, on the 19th of October, it left us with 50,779 active cases. But of these active cases, only 546 were recorded as serious or critical. That's only 1%. The rest, the other 50,233, 99%, were mild cases managed at home. And these are the cases that I referred to as COVID light. Now, obviously, the numbers of infections and serious cases are down, and it was much higher during the peak of the pandemic. But the mild cases, even during the peak of the pandemic, greatly outnumbered the serious cases. Now, in terms of why I decided to call it COVID light, let's just call it my quirky sense of humor, because, you know, you get QASA light and QASA lager, and you get Windhoek lager and Windhoek light. And I decided, okay, a milder version of COVID can be called COVID light. And that's how I came up with the term. But, you know, just to carry on, you know, the media is filled with the drama and the tragedies of serious cases, but very little is said about how to manage mild COVID infections. So I thought it would be good to write to it, because caring for mild cases in persons with disability would fall on the caregivers. And although mildly infected people aren't that ill, the potential to infect others may be as much as for severely ill patients. So the caregivers need advice on how best to protect themselves, especially seeing as that social distancing is not possible. And personal protective equipment, hospital level personal protective equipment is very difficult and expensive to obtain. So that in a nutshell was my reason for writing the article. Firstly, to make people aware that it's not a death sentence, and secondly, and more importantly, to give caregivers of people with disabilities the means to look after themselves and to protect themselves as far as possible from getting the infection.
Would you tell us a bit about how you found out that your wife was ill, and also what your thought processes were at the time?
Thanks, yeah, Raven. It's one of those things, you know, COVID light is in the air. And, oh no, not COVID, like COVID-19 is in the air, and everybody's talking about it, and the newspapers and the media are full with it. But you sort of live your life, and your friends and your neighbors and so on are all okay, and you a little bit localized in that your movement has been restricted and so on. But you know, it sort of doesn't feel like you're part of it. And then all of a sudden, it happens. it happened to us that soon after the stage 5 lockdown, my wife experienced mild body pains and chills, suggestive of flu, but no fever, no sore throat, no shortness of breath, no loss of smell or taste, or anything like that. And she sort of asked me if she should have herself tested. I was also in two minds about it, but I said to her, let's better be safe than sorry. But I had my doubts. So she went, and it was a freezing cold Thursday afternoon, early in April. And she had herself tested, stood in a queue outside the testing building in the cold and the wind and so on. And eventually she was allowed in, and she had herself tested. And 2 days later, on Saturday morning, around about 7 o'clock, she showed me an SMS that she had just received. She tested positive. So we were both somewhat incredulous. Wow, we didn't see this one coming. So I asked her how she felt, and she said she felt okay. So we sat down and we put together some ground rules for self-isolation. And we contacted my wife's GP. Although I'm medically qualified, I make a point of not treating my own family because of the subjectivity. So we phoned my wife's GP for advice on medication and monitoring. And from there, things progressed much as I described it in the article. We were both very calm about it. We were never scared or panicky, but we had, and we still have, a heightened sense of awareness about hygiene and masks and social distancing. So that in a nutshell is the story, the emotions behind the description in the article.
So, and as you mentioned now, especially with caregivers that is faced with the task of caring for the person who with a disability who will contract or who might contract COVID-19 or the coronavirus. But you share some very detailed advice on how to manage COVID light in the homes. But what do you think? What is the most important precaution to take?
You know, Raven, that is probably the most difficult question that I could be asked with regard to this article, because the caregiver-patient interaction in a home environment is so totally different from that in a hospital setup. You know, in a hospital setup, you've got PPEs and the whole infrastructure is geared towards protection of the caregiver. But in a home environment, the focus needs to be on being practical in the face of the realities of an imperfect caring environment. So I'm the first to agree that the recommendations that I gave in the article aren't ideal, that they're very open to criticism. But in my opinion, it's the best options open to us in a very imperfect environment. You know, social distancing is obviously out of the question in a situation where a caregiver has to turn a quadriplegic every couple of hours to prevent bed sores. And also to assist with bladder and bowel functions. I mean, you don't get closer and more intimate than that. And from a cost perspective, PPEs have to be substituted with less than ideal overclothes, such as aprons and rubber gloves, etc. So to answer your question, all that remains is to reduce the chances of caregiver infection. All that remains to reduce the chances of caregiver infection are firstly strict hygiene. You have to have personal hygiene with frequent washing of hands and sanitizing of your hands and so on. But also the work surfaces needs to be cleaned with substances such as jig or other types of bleach. You have to wear well-fitting masks and you know, everything that the media tells you to do. You have to be very strict about it. But secondly, you must try to reduce the infectivity of the patient. And as I mentioned in the article, the infectivity of a patient comes from the nasopharynx, which is the part in the back of the throat where the nose meets up with the throat. And that's where the bacteria sits, and then it migrates into little droplets, which you expire when you breathe or when you cough and when you sneeze. And so on. And if you can kill the virus in the place where it lives, the infectivity comes down. And it's been found that salt water salt and bicarb mixtures that you gargle with, or that you drop it with drops into the nostrils, tends to infiltrate the viruses, and they actually cause the viruses to burst and die. So that means you basically reducing the infectivity of the patient. So that's how how caregivers can protect themselves. But obviously, caregivers have to look after their wards, their patients as well, the persons with a disability. So the important thing is to check for shortness of breath, and that's where pulse oximeters come in. And it's not that expensive, but if you can't afford a pulse oximeter, or if you're not in close proximity to a pharmacy that will sell these things, then looking at the pulse rate is also quite important. If your pulse rate, as I mentioned in the article, suddenly jumps up 10 beats faster, let's say it was running at 70, now all of a sudden it's 80 or 90, and it stays like that, then it's time to contact the doctor and say, look, things are, even if the patient is not looking, is not demonstrating signs of shortness of breath, because these things, the shortness of breath can be hidden. It needn't be that obvious. But if the pulse goes up and it stays up, it's a sign that there's a shortage of oxygen in the blood, and it needs to be referred to a doctor. So in summary then, I described in the article methods for the caregivers to try and stay as hygienically as hygienically clean as possible, and also at the same time how to care for your patient to the best of your abilities as a non-medical person, which most caregivers usually are.
Mentioned some of the solution that can be used, and you mentioned the solution that to gargle with salt water, and also you mentioned now that it's not necessary to get expensive equipment to monitor the patient. Even someone that is knowledgeable or know how to check the pulse would work. And that for me is very significant, because the virus does not only affect people in affluent suburbs or only in the urban areas. It affects everyone on an equal basis. And we know how it was transmitted initially. We know how, and we also know how it spreads in our communities. And the solutions that you mentioned there is actually freely available. It only mentions with, it only needs someone to share the information. And that I just want to ask you on a personal level, why did you feel it was important to share not only the information now, but to share your experience, especially with the rolling readers?
Okay, let's start with my personal experience. I didn't want the article to come across as theory. I wanted the article to come across as personal experience. Because, it's like with anything in life. If there's a disaster, if there's, let's just for example say, take death in the family. If you've never experienced the death of a loved one, or a child, or a father, or a mother yourself, it is very difficult to put yourself in the shoes of somebody that has just experienced it. And then it's better to stay quiet and just to be there and to comfort, rather than to try and give advice and so on. But if you've been through an experience yourself, and you felt it on your own skin, like we say in Afrikaans, you feel it on your eie bas, then I think the advice that you are able to provide has more substance. So why did I decide to, why did I feel it was important to share this experience with rolling readers? It's two reasons. Firstly, to equip caregivers with guidance on how to care for their patients in a manner that reduces their chances of infection in this high exposure environment. And please note, I didn't say that will prevent the chances of infection. It just reduces the chances of infection. And that is why in the article, I urge caregivers to isolate themselves together with the people that they're caring for. And secondly, to reassure persons with disabilities as well as caregivers that contracting COVID-19 is not a death sentence, that the vast majority of infections will result in full recovery. The hype about ventilation and mortality is more about numbers than about the chances, and I'll explain that just now. The extremely high rate of infection means that during a peak, very large numbers of people are infected at the same time because of high infectivity. And although the percentage of serious cases are low, the numbers may be high enough to overwhelm the facilities. So if you get sick, the chances of it to be serious are fairly low. But if it becomes serious, the facilities to manage it must be there. Okay, now so let me give you an example with some hypothetical numbers. Let us say you stay in a small rural town in, let's say, Mpumalanga, and the town and the surrounding farms and small holdings and so on have about 100,000 people living in the vicinity of a hospital that carries 5 ICU beds. That's a fairly realistic scenario. Now let's say 1,000 of the 100,000 people get COVID in 1 week. That's only 1% of the population that gets COVID. But we've seen from the statistics that of the people that get sick, only about 1% get seriously ill. So 10%, 1% of 1,000 is only 10 people, but there's only 5 hospital beds. So you can see now there's 10 people competing for 5 beds. And that is the reason why we had a strict lockdown, to allow the country to set up these tent hospitals and set up hospitals in all sorts of centers and facilities and so on, so that we could create more beds with more ventilators and other infrastructure. But in our small town of 100,000 people, where 1,000 people were ill, there were 990 people with COVID light. That's 99% that were treated from home for COVID light. And people that do the treating need to understand that their fear of infection must be seen in the perspective of how few and far between the really serious infections are. And they also need to understand the basics of treating their wards that have now become patients in a manner that the patient can survive without having to go to hospital. So that really, in summary, is my reasons for writing this article. I must stress though, Graven, I'm not an expert in COVID. I'm writing from my own experiences and from the experiences that I've heard from friends and family, and also from information that was passed on to me, particularly from the Netcare Rehabilitation Hospital. I had lots of help from persons working there, so that I could get a perspective on how to manage COVID light in people with disabilities. So that's my story.
Thank you very much for your participation. Allow me to open up the floor and ask if there's any participants with questions for George.
Raven, while we're waiting, if I may, you know, when we go to the shops and when we go into public areas, we push ourselves with our hands, unless we have motorized wheelchairs. But if on a manual chair, we push ourselves with our hands. So we must be absolutely vigilant in terms of hand protection. And it would be worthwhile if you self-drive or wherever you go, in your wheelchair, if you've got a little bag or pocket that you store things like keys and so on, store a small bottle of hand sanitizer and sanitize your hands, because just by way of example, I've weakened quite considerably over the last 6 months. So I decided to return to the gym, just to take the bull by the horns and get back to the gym. And the gym that I go to have sanitizers available for each person going to the gym. And the other guys are spraying the equipment. I'm not spraying the equipment, I'm spraying my hands. Because before I touch the equipment and after I get off a piece of equipment, I spray my hands. Because my hands are the conduit, you know, and so looking after your hands as a wheelchair user is probably critical in protecting yourself.
There's another question that was posted. It's not visible in my chat box, but allow me to, Mariska, can you maybe convey the question that was posted, please?
Hi, Reverend. Yes, the question was just directed to George, and the person wanted to know, how did you deal with buying food or supplies while in isolation?
Yeah, thank you, Mariska. That's a very important question. We had opportunity, because I live in a complex where people, and we have family where people were able to deliver food, and we were able to do so. But I must also admit that it's you know, that there are practical realities, that in the instances where things were needed urgently, because I was healthy and I was totally symptom free, I would sanitize myself, I would wear my mask. I'd very early in the mornings, when the shops just opened, when there were very few people around, I'd pop over, I'd purchase what was needed, and then I would come back again, but I would do it on a social distancing and sanitizing principle. And yeah, so there were times that I had to take my chances, and I'm mentioning this to you to realize that, you know, you can't allow yourself to starve just because you have to social distance and isolate, and you don't have the infrastructure to support you. If you absolutely have to go to the shops, I know that Pick n Pay makes a point of opening up at 7 o'clock, and then they say that it's for pensioners only. So that's quite handy for me. But go early in the morning, before the big rush starts. Make sure that you know exactly what you want. Go for what you want. Don't dawdle around, and try and maintain, particularly at the cashier, your personal hygiene and your social distancing, and get out as soon as possible. And so that really, in essence, is how we dealt with it. And I know what I said is strictly speaking not all that legal, but it is the practical realities that we have to live with, and then we have to be responsible about it, and about how we go about it.
I see it's really as to what you do with what you have, where you are.
No, that's absolutely right. And you know, in the larger urban centers, some of the shops have now brought in delivery systems, but sometimes there's a couple of days delay in the delivery system, so that's not ideal as well. But if you're out in the sticks in a rural area, you really have to make do with what you have available to you, but then you need to do it in this manner that's as responsible as possible, and that's really the advice that I can give you.
Yes, and I see the onus is on you, responsibility as you to do. Because I mean, ultimately, we all are responsible for our health and our conditions. Yes. Even though we depend on caregivers, but you're still the person that must make the decision around the responsible healthcare. But thank you very much, George.